Our next speaker is Dr. Julia Coleman, and she's a trauma research fellow at the University of Colorado Trauma Research Lab, as well as a PGY-4 general surgery resident with plans to specialize in trauma surgery and surgery critical care. And her research interests are in trauma-induced coagulopathy and sex dimorphisms in coagulation. So we're thinking even further outside of the box here with respect to what may impact uterine hemostasis and vice versa.
Good evening. Thank you for bearing with me as the last talk. I want to thank the Foundation for Women and Girls with Bleeding Disorders for the privilege of the podium. And specifically, I want to thank Dr. Mann, Dr. James, and Dr. Funkhauser because they have really been my champions in advocating for me and have welcomed me into your lane of research. So it's truly a privilege to be here to learn from you. Today I'm going to speak about our work in sex dimorphisms and trauma-induced coagulopathy and consequent mechanistic exploration of a sex-specific survival benefit. We appreciate funding from the Foundation for Women and Girls with Bleeding Disorders as well as the NIH in the form of T32 funding, and also receive consumable support from instrumentation laboratories and hemonetics. Sex dimorphisms exist in nature. In birds, one can most readily distinguish phenotypically between males and females. These same drastic dimorphisms exist in humans. Yet, many basic and clinical investigations have not accounted for sex as a biological variable and a possible mediator in disease processes. Recognizing this, the NIH recently charged the scientific community with accounting for sex as a biological variable in experimental design in all future grant-funded studies. These drastic dimorphisms exist in coagulation. Specifically, we know that females are relatively more hypercoagulable than males. Shorter time to clot formation, greater rate of clot propagation, greater clot strength. And the question is, why does this matter? Do we care? We do, because it makes a difference clinically. We recently published the results of a bi-institutional study looking at all trauma activation patients at 2 level 1 trauma centers and identified that after severe injury, female-specific hypercoagulability persists, and in the setting of trauma-induced coagulopathy, female sex confers a survival benefit. So when we observed this 2 years ago, we then asked ourselves, what is the reason for this population-level observation, and what is the mechanistic explanation? When you look at a thromboglastrographic tracing of males versus females, you can see there are several differences in hemostatic capacity. There's a shorter reaction time in females, there's a greater angle or rate of clot propagation, and a greater maximum amplitude or clot strength. And so you can see there are a myriad of differences. Consequently, there's probably a myriad of mechanistic explanations. Can this be explained by sex hormones? There's certainly some literature to suggest that may be it. But could it also be explained by differences in cellular biology? That potentially could be another reason. So, in a series of experiments, we first started looking at the effect of sex hormones on the enzymatic phase of coagulation. We hypothesized that progesterone and estradiol have a procoagulant effect in vitro. We collected blood from healthy volunteers, 10 premenopausal females, non-pregnant, not on OCPs, and 10 similarly aged males. And then we performed citrated native tag and TPA challenge tag, which I'll explain on the next slide, and did those side by side in the presence of physiologic concentrations of estradiol and progesterone. You saw on the previous presentation some information about TAG, but we're all familiar with this. It's a whole blood viscoelastic assay, which describes the R time or reaction time, which is the time to clot formation, enzymatic coagulation phase, angle of the rate of clot propagation, which is an effect of fibrinogen and fibrin, MA, maximal amplitude, which is the maximal clot strength achieved, an effect of platelets, and then LY30, fibrinolysis 30 minutes after MA. You can further describe fibrinolysis through addition of tissue plasminogen activator to describe the degree of TPA-mediated fibrinolysis in vitro as well. So amongst our 20 healthy volunteers, we found that estradiol shortens R time, specifically in females. Doesn't affect angle, MA, or LY30, but decreased the R time from 12.2 to 8.2 median on a citrated native tag. There was no effect in males. Interestingly, we also did not see any effects with progesterone. When we performed the TPA challenge tag, we saw then some differences we previously didn't see with estradiol alone. Specifically, estradiol then shortened our time in females and males, and estradiol increased angle and MA in males and females respectively. This is a perplexing part of our results we don't quite understand, but suggests there may be some interaction with estradiol and TPA receptors. Overall, the clear signal that we got from that was that estradiol has a procoagulant effect in females. And this may indeed explain why we see a shorter reaction time in females. We know that the reaction time is an effect of the enzymatic phase of coagulation, so we took that a step further and looked at whole blood thrombin generation, which is a newer assay in the world of trauma that we're now starting to adopt. And we found that indeed, healthy volunteers, amongst those, females have a greater rate of thrombin generation in whole blood. And when you add estradiol and incubate it with the blood, you again see that this is further exaggerated in the presence of estradiol in females specifically. After having identified that indeed hormones can exaggerate this female-specific shortened R time, we then wanted to look at this difference in maximum amplitude and the platelet response between males and females. This is an interesting area of research because we know that platelets are highly decorated with both estradiol and androgen receptors. And this is particularly interesting because we think of these steroid receptors as nuclear receptors, yet they're on anucleate cells. And so this has opened a whole chapter of research looking at the non-genomic effects of these receptors, which is quite fascinating. Our group has recently shown that both female and male platelets express equivalent densities of these receptors. So the question is, the difference between platelets in males and females, is this due to circulating sex hormone levels alone, or are there intrinsic differences in their actual sex hormone receptors? And why does this matter? Because have you ever thought, when you hang a bag of platelets, where did those platelets come from? Was the donor male or female? And does it matter? Our work would suggest that it does. We hypothesize that platelets from females have increased response to stimuli as compared to platelets from males, given this difference we observed in TEG, and that estradiol increases platelet response to stimuli, much in the way we saw this same exaggeration of female hypercoagulability with TEG. First, I'm going to walk you through this first hypothesis. We collected apheresis platelets from healthy volunteers at our local donor center, so these are the same platelets we're transfusing in our patients. And we separated those by pre- and postmenopausal females based on the average age of menopause of 54 years old and compared those to similarly aged males. We stimulated platelets with ADP and platelet activating factor and then performed platelet function tests, specifically looking at aggregation and activation, which I'll explain in the next few slides. The reason why we chose specifically to stimulate platelets with platelet activating factor and ADP is because these two stimulants are known specifically to cause a robust increase in fibrinogen binding capacity. Platelet activating factor is released from endothelial cells and platelets and stimulates the P2Y1 receptor, which through G-stimulatory coupling causes an increase in calcium and potentiates platelet aggregation and activation. ADP is released from dense granules of platelets, and it stimulates the P2Y1 receptor and the P2Y12 receptor, which through G-inhibitory coupled signaling modulates levels of cyclic AMP and again potentiates platelet aggregation and activation. After stimulating platelets with these two stimulants, we then measured platelet aggregation. When platelets are activated, as we know, they have changes in their cytoskeletal structure, and that can be measured through extent shape change, which is a metric that is a proxy for the propensity for aggregation of platelets. We also looked at platelet activation through CD41 cell surface expression. CD41, or as you may know it, the alpha-2b beta-3 receptor, is the fibrinogen receptor. And when platelets are stimulated, they mobilize their receptors to the surface, and through flow cytometry, you can detect and quantify the expression of this receptor. This data included 53 healthy volunteers, 12 pre- and 13 postmenopausal females, and then 15 and 13 similarly aged males. You can see their average age here and the age range. First, when we looked at platelet aggregation, females had significantly increased platelet aggregation in the presence of ADP stimulation, whereas we did not see a difference with platelet activating factor. With platelet activation, similarly to how we saw robust aggregation with females with ADP, female platelets also had robust fibrinogen binding capacity in the presence of ADP stimulation, whereas there was no change in platelets from males. Conversely, in the presence of platelet activating factor stimulation, male platelets had robust increase in platelet activation, whereas female platelets did not, suggesting a sex-specific activation potential. Having identified these baseline differences in their activation and aggregation potentials, we then looked at the effects of estradiol on this behavior. We performed the same set of experiments with 21 consequent donors, but we pre-treated the platelets by incubating them in physiologic concentrations of estradiol for 15 minutes, and then performed the same stimulation and platelet function tests. Whereas previously we saw that females had a robust increase in aggregation with ADP stimulation, after estradiol pretreatment, the feminized male platelets aggregation approximated that of female platelets. When we then looked at platelet activation in the presence of estradiol, previously we saw a robust increase in activation in female platelets with ADP. This was diminished in the presence of estradiol, but interestingly, both male and female platelets had robust activation in the presence of estradiol. I just gave you a lot of numbers and data. I'm going to walk through a visual schematic for those of you that are visual like myself. We know megakaryocytes have androgen and estrogen receptors. Those persist in the lineage of platelets. Those platelets also have the P2Y1 and P2Y12 receptors on them. In the presence of ADP stimulation, female platelets have significantly increased aggregation and activation. In the presence of platelet activating factor stimulation, however, male platelets have significantly increased activation. And after estradiol pretreatment, we see that the male platelet aggregation approximates that of females, and both male and female platelets have robust increase in their activation. So we identified baseline differences in the platelet behavior, which can then be modulated by estradiol in just a 15-minute incubation. In summary, we identified a cellular response. Platelets from females have increased aggregation and activation with ADP, whereas platelets from males have increased activation with platelet activating factor. And we identified a hormonal effect, such that estradiol treatment causes a feminized male platelet to have aggregation behavior that approximates that of female platelets. Why does this matter? We think this has pretty widespread implications, even though this is preliminary data, and that female and male platelets are not the same, and call into question whether donor sex should be considered in transfusion practices, and whether potentially we should have therapeutic sex-specific selection of platelets in resuscitation practices, and even whether estradiol should be considered as a therapeutic adjunct in resuscitation practices. This is not a new concept. Estradiol has been explored as an adjunct in neurotrauma, for example. So, I know all of you are sitting here and you're thinking, isn't this the uterine hemostasis colloquium? Why is she up here talking about trauma patients? Well, I'll take you back to where we all started. Initially, we identified this sex-specific survival benefit in females in the setting of trauma-induced coagulopathy, and then through mechanistic exploration, identified that some of this may be driven by sex hormones and intrinsic differences in platelet biology. So then we got interested in looking at sex-specific states of sex hormones. So looking at, for example, pregnancy. How is this different in pregnancy, and how is it different when deranged, such as in postpartum hemorrhage? And when we started to do this work, we found that actually trauma-induced coagulopathy is very similar to postpartum hemorrhage coagulopathy. And I realize this is a controversial statement and something that we're still debating at my own institution. But I will give you my case. We know that postpartum hemorrhage, it's highly prevalent cause of morbidity and mortality worldwide in women. And when we first learn about postpartum hemorrhage in medical school, they talk about the 4 T's of postpartum hemorrhage: tone, trauma, tissue, and thrombin. And that postpartum hemorrhage coagulopathy is characterized by dilution, localized consumption, DIC, increased fibrinolysis, as we just heard about, and hypofibrinogenemia. These are the same aspects of trauma-induced coagulopathy: vascular tone, tissue injury, tissue factor release, and thrombin activity. So I've been told by my esteemed OB-GYN colleagues at the hospital at Denver Health, Well, postpartum hemorrhage is just a mechanical issue. All it is uterine tone. Well, I would purport that there's actually a component of coagulopathy that's very similar to TIC. We've examined this looking at whole blood thrombin generation. Everyone here in the room probably has much more experience with whole blood thrombin generation than I do, but we are just now using this in trauma patients. So there are 3 sites in the country that are using a prototype point-of-care device to look at whole blood thrombin generation in trauma patients. And I said, why don't we use this to look at postpartum hemorrhage at Denver Health? Because they have nearly double the rate of postpartum hemorrhage. As you know, thrombin generation gives you lag time, the time to thrombin, peak thrombin, the time to peak, the maximum rate of thrombin generation, and what we really care about, ETP, endogenous thrombin potential, which is the total amount of thrombin that can be generated under pro and anticoagulant forces. We've now identified at our institution that pregnant women compared to non-pregnant women have higher peak thrombin and higher ETP when you look at whole blood. Well, we wanted to look at this in PPH and see if it's similar to trauma-induced coagulopathy, hypothesizing that women with PPH have decreased whole blood thrombin generation compared to non-PPH females, and that this coagulopathy is dynamic and resolves within 4 hours. Why we chose 4 hours, I can talk to you about offline, but it also has to do with regulation and what we're capable of looking at. I suspected this would be actually at a longer window than 4 hours. Our methods right now, this is an ongoing study where we're looking prospectively at all postpartum hemorrhage patients at our hospital. As soon as a patient develops postpartum hemorrhage, we get a page, someone calls and draws blood immediately upon diagnosis, and then 2 and 4 hours later. And we're comparing myriad of assays, including thrombin generation, to longitudinal patients that we're also following along, and we get their blood drawn after delivery and at 2 and 4 hours after. And those women, so far, none of them have developed postpartum hemorrhage. So we have 18 postpartum hemorrhage women that we've included in this study that is still ongoing. They are young, multiparous women that are coming in at term, and a few of them do have some predeterminants of postpartum hemorrhage. Their median systolic blood pressure is 125, despite losing over a liter of blood, which is what we are used to seeing. You can see their median labs here and their tag, and notably, all of these women are in fibrinolytic shutdown, as we've discussed. Postpartum hemorrhage is indeed characterized by depressed thrombin generation. It is not just a mechanical problem. There's a longer lag time, a lower peak thrombin, a longer time to peak thrombin, and a lower maximum rate of thrombin generation. If you look here, you can see the red series are all our PPH patients, and the green and purple are our control, quote-unquote, patients without PPH. And there are no differences in their baseline demographic features, but they indeed have a difference in their coagulation profile. And it's dynamic. When we look at hour 0 and hour 2, the majority of women who have developed PPH, in terms of their thrombin generation, it is normalized by hour 2. So much like TIC, it's a very dynamic process. We are now starting to enroll enough women that we do have the unfortunate cases of where a female has decompensated and she gets an emergent hysterectomy or gets massively transfused, which, as we've heard, it happens very infrequently. They don't have this recovery in their thrombin generation. In summary, PPH is characterized by deranged whole blood thrombin generation, and it's a dynamic process. This is very much like what we see in trauma-induced coagulopathy. So I believe that there's a lot that we can learn from each other in treating these patients. And to bring this all back home with what I was talking about earlier with this basic science research, I think a lot of the things that we're finding in our bench work inspired from trauma-induced coagulopathy may also translate to postpartum hemorrhage. Could maybe sex hormones be at play in postpartum hemorrhage, the circulating levels, and whether those are decreased or different in women that develop postpartum hemorrhage? And potentially, should we be considering sex hormones as therapeutic adjuncts in treatment of PPH coagulopathy that does not resolve in the first 2-hour window? I'd like to thank you all for your attention. I'll be happy to entertain questions at this time.
I noted in looking at your TEG versus whole blood analyses, they provided very different results in that same population. I'm wondering how much of the TEG result is a consequence of different fibrinogen levels in these women as compared to men, and in terms of coagulation levels. If you look at your slide where you looked at your postpartum hemorrhage normals versus affected individuals, In the normal population, you see there's a very different, very heterogeneous mix of thrombin generation. And that's probably due to basically the blood clotting factor composition in these individuals. And so I would recommend that you do a comprehensive coagulation factor analysis in that population, just in a healthy population.
Thank you so much, Dr. Mann. A couple comments on that. One thing that is interesting is that TEG is not differentiating PPH and non-PPH patients, which I didn't really go into for the sake of time. There's so much that I would love to talk to people about, but it's limited time. So I didn't get to that, but TEG didn't detect differences, whereas whole blood thrombin generation did. And why I think it's important that we're looking at whole blood thrombin generation is because yes, plasma thrombin generation is a useful tool, but we know that there are cellular contributions to thrombin generation. And that is also, I realize, a controversial topic, but there's some thought that platelets actually contribute and provide scaffolding for thrombin generation. So I think this is really important that we use this tool. I did not describe fibrinogen, that's something that we're looking at, and this is just a sample of what we're looking at in these PPH patients. So we're actually spinning down their plasma, and we are Dr. Moore, my PI, does not like when I talk about all the things that we're doing, but I believe in collegiality. We spin down the blood to plasma, and we're banking it, and we're looking at all the coagulation factors in the coagulation factor cascade. We're looking at 2, 5, 7, 9, 10, 11, and 12. And also looking at some of the additional mediators that I have some interest in, such as TAFI, and in addition to that, doing some proteomic analysis with our omics lab. So that, I think, is going to be a very generous bout of information. And also that includes looking at conventional coagulation assays and fibrinogen as well. So thank you so much for that suggestion, and we're following that.
That was really fun.
I was not sure how you were going to end that sentence, but I'll take it. Okay.
When you're making cupcakes, it sort of depends when you add the eggs, whether you add it to the dough before you put it in the oven or after. So if you look at the platelet receptors from the platelets that are cooked in the megakaryocyte, it would be different than taking the ones that are cooked and then dipping them in estrogen. Or another way, the estrogen effects that you observed by adding it externally may not reflect a more important factor, which may be the endogenous estrogen exposure during megakaryocyte proliferation, fragmentation, and platelet formation. So it may be post facto, and the important thing may be while it's being made.
Absolutely, and I've got two comments for that. Thank you. One is, I think one of the issues with the platelet study is we don't really know what's the biochemical status of those women. So we sort of said, okay, we're going to use this average age cutoff of 54 and say they're pre and postmenopausal, but we really don't know that, and we don't know what their circulating sex hormone levels are. Even in the premenopausal women, turns out that we know, because we're also looking now at the changes in coagulation over the menstrual cycle, certainly, which has been done by others as well, but it even matters where in the estrous cycle a premenopausal female is for their platelet behavior. So I think that's one of the issues with this data, and so this started as us just collecting platelets from donors. We've now got an IRB-approved study where we can actually now also do biochemical confirmation of what their sex hormone status is, and I think that might be one step closer to looking at what you're getting at. I think ideally what would be nice is to actually get megakaryocytes from some of these people as well, which is even more of a challenge with IRB that I've taken on. And another point that I would say that's sort of perplexing is when we looked at the expression of the estradiol receptor, it didn't change at all with estradiol incubation, which was sort of interesting, and also wasn't different between males and females, which is very interesting at baseline before we really did anything besides take it from the body. So I think there are a lot of things that are still yet to be done in this work. Thank you so much for your thoughts.
Roshni Kulkarni, Michigan State. And so you remind me of something that Yuri Martinowitz, who's a hematologist in Israel, did a lot of work on Novo 7. He called himself a hematotraumatologist because he used to go to all these, people who were blown up and whatnot and rescue them. And I think you represent a traumatohematologist. That's your title.
I've
But I was
never received that
fascinated.
compliment. Thank you, I think.
So I think your study is fascinating, and I was just wondering if you see how far do you see these sex differences? Do you see that in girls? I mean, as a pediatric hematologist, I'm wondering whether menstruation is the beginning of these differences, or whether you see it before or after. And so, I saw you showed the different ages, so I was curious
Yes.
to see whether there were any children involved.
So we've only looked at adults, and also I have given you just a snippet of the work that we've done in the last year that the foundation has so generously supported, and there's so much still to be done. This is one of so many roadmaps that I've created of the experiments that we're doing to look at this, because there's still so much that needs to be done. And I've only told you about 2 portions of a lot of what we're going to be looking at. I think intracellular signaling in the platelets is the next big step. And I think doing some of this biochemical confirmation. And right now we're looking at premenopausal females who are not on OCPs, which are harder to find than you would think, that are willing to let me draw their blood 3 times in a month to look at actually their changes in their coagulation during the menstrual cycle. But there are a lot of future directions with this, none of which I have considered yet in minors, but that's certainly something that I think is worth looking at. Because interestingly, now that we're doing more, and sorry, Dr. James, I'm really going here, you'll have to stop me. But the last point that I would say,
I'm just planning the talks for our 2020 meeting. You just keep going.
well, the next thing that I would say is we've collected more and more of this platelet data to get a larger sample size, and this robust increase in aggregation and activation in female platelets is most pronounced in the postmenopausal females. Most pronounced in the postmenopausal females, which is really not what I expected. And don't you hate when that happens? So, and I think it brings up the point of whether there are actually these differences in platelet behavior that we're seeing, and these differences, whether it's driven by the circulating sex hormones themselves, or whether a lifetime of being bathed, your megakaryocytes in your bone marrow being bathed in this milieu of sex hormones, whether that is creating differences. And I am really, as you were using the word earlier, I'm really speculating here out loud, but I mean, I think that may be what we discover, and what was sort of alluded to with an earlier question, is that this isn't just about the circulating sex hormones themselves, but about a lifetime exposure to them.
Very nice work, Julia. Gawar Pali from Duke. And so with the normal males and female studies that you've done with platelets or the tags, what's the noise in the system? Because it was really hard to tell, what's the variability in males and females and their responses, in terms of tag. You showed some of the biological variation in the box and whisker plots for platelet aggregation, but, in terms of, is that a limited number? Or if you were to study a lot more donors, what would be the variation in your system with the assays that you're looking at?
That's a great question, and I'm going to have to come back to you offline because I can give you actual meaningful numbers for that. Because I would say the data's not perfect. It's not completely clean. Again, I talked about this noise of catching at what cycle of estrus you catch the premenopausal females, but I haven't even brought up this whole nother issue of obesity and the fact that adipose tissue releases estrone, and that interacts with this beta-2 receptor that the estradiol that I looked at is interacting with. So the data's not perfect. There's a lot of noise, which is okay because humans aren't perfect, and what we're looking at are imperfect phenomena. And so there is noise, definitely. Is what we see in the performance of the machine of thrombin generation and TEG acceptable? I think so, and I can give you the actual numbers for that later. But I think now that we've gotten this interesting signal, trying to tease out some of that noise is going to be extremely helpful. I know that's not answering your question
No, what you-
exactly, but
But no, what it gets at is, you may want to study the extremes, and to characterize the biological effects. So once you understand mechanisms, once you understand what's happening with the ER receptor and signaling, then maybe then you can have much more specific tools or targets that you're looking at in the broader population.
thank you. It's a great idea. Thank you.
Just to comment on your question, everybody's familiar with the prothrombin time being about 11 seconds in a normal population. The reason it's 11 seconds is because when Quick first started doing those studies with rabbit brain thromboplastin and all that kind of stuff, what they realized was that if you dilute the thromboplastin, if you like, and you look at individuals, that they're very heterogeneous with respect to the prothrombin time. So we basically amped up the amount of activator to eliminate the difference. And basically, if you look at, there's quite a lot of publications on phenotypic heterogeneity in thrombin generation, both empirical and theoretical. And so, including in situations like implantation studies with women for fertility, that there's increased thrombin generation. But you'll only see it if you use technology that is sensitive to phenotypic heterogeneity in the population. And unfortunately, physicians like the idea of normal values, and there's no normal value. Nobody is normal. Nobody looks like anybody else in this room, and the same thing is true at the biochemical level.
Yeah, and I would say the whole blood thrombin generation data in trauma patients, so far we have 112 severely injured trauma patients that we've collected data on the last 14 months. And it's right now a little disappointing because it's not actually showing, it's not getting into the granularity of TIC, which is why I think it's so interesting that we're seeing it in the postpartum hemorrhage patients already very early. And now we've got 48 patients and it's an even stronger signal. So we'll see how it pans out.
Wonderful. Thank you so much. Thank you, Julia. Thank you, all of our speakers, for an extremely stimulating panel and extremely stimulating questions. Thank you to our participants. We'll reconvene back here in 12 hours for breakfast. Carrie, are there any other announcements we should make at this time? Okay, did you hear Carrie? Fill out the evaluation and leave it in your chair or at the back. And breakfast will be in the room. And we'll convene at breakfast at 7 and then our talk start at 7:30. Thanks again.